Good afternoon, everybody. Today I'm going to talk about sinusitis. And I want to start out with the basics and just discuss where and what the sinuses are and what sinusitis is. So your sinuses are these spaces in the face, below the eyes, above the eyes, between the eyes, and behind the eye. And we really don't know why we have sinuses, whether it's to humidify the air, filter the air, lighten the head, or it has something to do with smell or sound. Nevertheless, three of the sinuses, the maxillary, frontal, and sphenoid, are all structured in the same way as a large space with a narrow opening, much like a balloon. That opening is called an ostia, and that connects the sinus space to the nasal space. And that's really critical in our understanding of sinusitis, as I'm going to speak about. Sinusitis occurs when this opening gets blocked and we have pressure that develops within the sinus cavity. That pressure causes swelling of the lining and fluid to accumulate that then gives you the symptoms of sinusitis. And as we talk about in the nose and the sinuses, millimeters matter. And the difference between 2 and 4 millimeters is dramatic as far as breathing and as far as the symptoms and problems you can get with sinusitis. We get a sinusitis cycle that occurs when we start out with a sinus ostia that is blocked. Sinus ostia can be blocked from allergies, from a simple upper respiratory infection, from foreign bodies, from anything that gives you edema in your nose. But then that blockage leads to negative pressure in the sinus space, which causes secretions to develop that then stagnate and provide a perfect milieu for bacteria to grow. And this causes more swelling, more bacterial infection, more inflammation, and more blockage. And this becomes a sinusitis cycle that is self-fulfilling. What does the patient notice? Well, the patient can notice drainage, whether coming in the front as snot or boogies, in the back as postnasal drip or phlegm, congestion, either in the nose or in the face in general, pressure in the ears or nose, cough, dental pain because the maxillary dentition roots are at the floor of the maxillary sinus. So if there's pus in the sinus, it can irritate roots if the bone is very thin or there's no bone there. Decreased smell, clogged ears as the drainage goes down the back of the nose past the eustachian tubes and causes a secondary swelling and blockage of the eustachian tubes. Sore throat as drainage goes down the throat and causes infected drainage to irritate the mucosa of the pharynx. Even if you don't have visible erythema, edema, or a problem there, they can have a sore throat. Bad breath and chronic throat clearing. There are different types of sinusitis. As with every infection or every problem, there's an entire spectrum. And acute sinusitis is exactly that. It is sinusitis that has simply occurred for a few weeks, usually after a cold or some triggering event that is frequently associated with pain and purulent drainage. I'm not really going to be talking about acute sinusitis today at all. That is something more within the area of a primary care practitioner, internist, pediatrician. I'm going to be discussing more so things that are longer lasting. Recurrent acute infections are when you have an acute infection, you think you get better, it's all gone, and then a month later or 2 months later, it's back again. And then it gets better, and a month or two later, it's back again. And year after year, you're getting 4 or 5 infections every time you get a cold. That is not just an acute sinus infection each time. And chronic sinusitis is something that just doesn't go away. You always have a drip going down. You always have pressure in your face. And this can last for weeks, months, or 20 or 30 years, depending on if you choose to correct it. So the first medical management for sinusitis, the option that is the most holistic, cheapest, safest, and easiest is simply washing your nose. And nasal saline sprays are available in many different ways over the counter without a prescription. There are simply spray bottles, there are cans, and then there are options like the Neti Pot and Neilmed Sinus Rinse that you make yourself. Any of these work very well in washing your nose. And for some people, simply cleaning your nose several times a day will resolve a recurrent acute or chronic sinus problem or even an acute problem. there's a few pearls to know about this. Number one, you can't wash too much, but if you do a measure that is high volume, like the neti pot, or high pressure, it can flood the back of your nose and cause a eustachian tube blockage. So that's one thing to be aware of, especially if eustachian tube blockage and pressure is a problem. You don't want to use the high volume, high pressure methods because you can be continuing the problem as opposed to fixing it. Also, if you are making it yourself, you want to use clean water. Tap water is not clean. In fact, studies have even found that filtered water is not clean enough. So they need to be using boiled water or distilled water. And you want to clean your vessel, whether it's Neilmed Sinus Rinse or neti pot, on a weekly basis with alcohol, iodine, or vinegar, so that the bottle itself doesn't have bacteria in it, that you're recontaminating your nose regularly and you're not getting better because of how you're trying to help the problem. And you want to make sure it's dry in between so there's no chance mold or fungus can be growing in your bottle and then you're putting it back in your nose. The next measure of medical treatment after washing your nose with saline sprays are the nasal steroid sprays. Some of these are still prescription, many of these are over the counter, some are both, depending on the insurance. These work, as steroids do, in decreasing inflammation in the nose, because the whole goal is to open the ostia so that air can ventilate the sinus again. And these sprays topically go in your nose to decrease swelling, but you must know that it takes about 5 to 7 days for them to really kick in. They are not like Afrin, where you're going to have a change in an hour. So you want to use them for at least 2 weeks at a time, not as needed. And they only work where you spray. So you want to make sure they are angled where the ostium are, which are on the lateral side of the nasal cavity. So it's very important to explain to patients that when you spray, you want to point from the center to the side and back, sort of towards the eye above the ear. Not just squirt it down your throat where it will do nothing. And if you squirt it medially to the septum, you can cause a nosebleed. If saline sprays and nasal steroids have been used for several weeks or months and they're not helping, the next intervention medically is an antibiotic. And different antibiotics kill different bacteria. As an ear, nose, and throat specialist, as we culture patients with chronic sinusitis, we see everything from MRSA, Pseudomonas, Serratia, E. coli, things that wouldn't normally be expected in acute sinusitis, which is typically H. flu, strep pneumonia, and Moraxella catarrhalis. So as I see patients, it's very important for me, for maximal medical therapy, to try different families of antibiotic coverage and to provide a minimum of 10 days. Studies have shown that at 7 days, even if a patient symptomatically feels better, there is a bacterial load still within the sinus. And at 10 days, that load is insignificant. So in general, I usually give patients 14 days or 2 weeks course, trying different courses and different families of antibiotics. Then oral steroids also come into play with medical management of chronic sinusitis and recurrent acute, because sinusitis, by definition, is an inflammatory disease. It is inflammation of the sinus linings. And the strongest anti-inflammatory are oral steroids. So if someone has acute pain, or someone is not improving, or their congestion is never resolving, adding a Medrol dose pack or a course of prednisone is a reasonable thing to try to kickstart their improvement and let the sprays work and get in. Another thing that's very important is to look at triggers. And these are various triggers that I always evaluate with patients who have recurrent or chronic problems. Dirty air and water. Unfortunately, our ocean is not that clean. And it is common to see surfers who surf regularly, have tumbles, get the water in their sinuses, and the bacteria in the water is a trigger for sinus infections. And the best thing they can do is come out of the water or a pool or anything that is dirty and wash your nose and try to clean it out so the dirty water isn't drying and the bacteria is laying in your sinuses, being a trigger for recurrent infection. Teachers are surrounded by little kids who are coughing, sneezing, and blowing their nose in their face, and often are in moldy classrooms, and they are in an environment that is dirty. And I see a lot of elementary school and preschool teachers with chronic sinusitis. And then flight attendants have the triple whammy of dry air, recirculated dirty air, and barotrauma of the elevation and pressure changes in a plane. So these are really common risk professions for chronic sinusitis. Other triggers that we want to try to control are allergies. If allergies are not well controlled, they are going to give you edema and drainage in your nose to block that ostia and be a reason that recurrent sinusitis or chronic sinusitis is not well controlled. And then physical obstruction, whether in a child who has a foreign body in their nose, polyps, or even a tumor. Any of those can be a reason for recurrent or chronic sinusitis. There are so many things in medicine we don't know in most diseases, but even in sinusitis. And there recently, last year, was an international symposium on allergy and rhinology. And all of these are factors that have been hypothesized to be the reason that some people get better from a sinus infection and some people don't, or some people become recurrent and some people don't. All of these have been investigated and hypothesized, and there has been no clinical evidence to determine a role in any of them yet. I'm sure eventually we will learn there is a genetic predisposition for certain diseases. There are immune differences between different patients, but at this point in time, we really just don't know. When someone has attempted to treat their sinuses with maximal medical therapy, then there are a few other measures that we can evaluate a patient's situation. First, nasal endoscopy. The fiber optics have really changed ENT and a lot of medicine. And with a scope in the office and topical anesthesia, we can look in the nose and see what someone with a nasal speculum and a flashlight or headlight cannot. So many of the patients I'm going to talk about today, you could look in their nostril and see nothing. No edema, no redness, no boogies, no drainage. You look in their throat and see nothing. And yet if you took a scope and you looked in their nose, this is the septum, this is the middle turbinate, and this is the lateral wall of the nasal cavity. This area is the middle meatus. This is the bottleneck where the frontal, ethmoid, and maxillary sinuses ventilate through or drain. And here you see edema and pus. This is someone with chronic sinusitis who has evidence on endoscopy, even if on their regular general ENT exam you see nothing. And in the back, likewise, this is the nasopharynx, the palate. The eustachian tube is right here, and this is mucopurulent drainage. This is pus draining down the back. This is the reason for the chronic cough, the snorting up of phlegm, and for their ear to be clogged. You would only see this on nasal endoscopy. If after nasal endoscopy, maximal medical therapy is done and we want to pursue something more aggressive like a procedure or surgery, we next get a CAT scan. And a CAT scan takes your head and basically slices it like a loaf of bread to look at your sinuses and face in slices. So just to orient you, white is bone, black is air. And this is as if you've sliced your face from the front to the back. So these are the eyeballs, this is the brain, this is the mouth and the teeth, and you can see the dental roots coming up against the maxillary sinus. These are the ethmoid sinuses between the eyes, and below the eyes, this is the left maxillary sinus, which looks totally normal. You should see black air on white bone and no gray. And you should also be able to, like a maze, follow the black air from the sinus cavity into the nasal cavity. That is a normal anatomy right here. In contrast, on the right side, this is abnormal. This is thickened lining and an obstructed ostia. This is a reason for chronic sinusitis. So if this is the CAT scan that someone has after months of saline and steroid sprays and multiple courses of different antibiotics, they have a problem still despite maximal medical therapy and are a candidate for something more aggressive. So this is a normal coronal CAT scan. Brain, frontal sinuses, eyes, ethmoid sinuses, maxillary sinuses. And this is an abnormal coronal CAT scan. Here we can see thickened lining and fluid in the frontal sinuses, thickened lining in the ethmoid sinuses, and maxillary sinuses that are basically full of fluid. A few things that are important, at least from my perspective. To me, a CAT scan is most useful after a patient has tried multiple courses of maximal medical therapy. Someone with a cold could have a CAT scan like this, and a week later, when their virus resolves, their CAT scan will be normal. So a CAT scan in itself doesn't tell us enough information unless they have already had medical therapy and it has failed to improve their chronic symptoms. So, and then in that time frame, the CAT scan helps determine if they are a candidate for surgery, where surgery needs to be done, and helps us look at their anatomies since we're working right up against the eye and right below the brain. In rare cases, if you're uncertain if someone just has allergies or has a migraine, then a CAT scan can help you differentiate, do they have a normal sinus anatomy or do they have a chronic sinusitis? Sinus surgical techniques over the past few decades have evolved tremendously. And when I started training at the University of Pennsylvania in the 1990s, people did sinus surgery with a headlight and a nasal speculum, and basically punched a hole in the sinus because at that time we thought that you just needed to drain the sinus. Oftentimes a procedure called a Caldwell-Luck, where you went into the gums and punched a hole and sucked out all the drainage and ripped out all the lining and then packed it because it bled massively, and sometimes these people were admitted. That is how sinus surgery was done. And in the early 1990s, David Kennedy, who was our chairman at Penn, came from Europe and brought endoscopic techniques using concepts from the ear to look endoscopically at the sinus anatomy. And it was discovered that just putting an extra hole in the sinus didn't fix the problem. And the key area anatomically was the ostium, was the place where the sinuses needed to naturally ventilate. And that area, since then, is the area that we now open and enlarge to allow better ventilation of the sinuses. And over time, because of endoscopic visualization, surgery is more accurate, safer, and still can be more aggressive. We also have stopped packing with yards and yards of Vaseline gauze that you have to rip out days later. Currently, I just put a gel in that you wash out or suck out that really does not cause pain and doesn't cause a new raw surface. And there's many different new technologies that have made sinus surgery more effective, safer, and more successful. I'm going to review some of them now. Three-dimensional imaging has made sinus surgery much safer. And currently, there is technology that allows me to look at a coronal, sagittal, and axial CAT scan while I place instruments into the nose. So this is a patient on the table, and I am looking through their nostril. And as I put instruments in, I can see where I am in the sinus, which is very important when you're trying to clean up against the orbit, but do not want to violate a vital structure like the eye or along the skull base like the brain. The microdebrider is essentially like a lawnmower, and when you have polyps, the microdebrider allows you to suck up a polyp and shave it at its base without ruining or removing normal mucosa, because the goal is that the mucosa relines the spaces and you have healthy, clean mucosa. But in the old days, when they ripped it all out, all you got was scarring, and it really didn't cause the same natural anatomy to be replaced after surgery. So microdebriders have been very helpful with patients with polyps. The hydrodebrider is also very helpful. These sinuses are spaces around corners and are not a straight shot. So in the maxillary sinus, frequently you're going in the nose and making a sharp left turn and then going down. And in some patients with chronic sinusitis, they have thick glue-like mucus, much like you would see in a glue ear on a child who's had chronic ear infections. And in some patients with chronic infections, they grow hard concretions, really rock-hard boogies or gray, thick fungal balls. And these need to be removed for their infection to go away. But you can't always grab them or suction them. The hydrodebrider allows you to place this instrument in, go around a corner, and then spray it like a sprinkler and suction it out, and literally hose it out. And has really been very helpful in those difficult situations. Propel is another technology that recently has come out, and this allows an implant that looks like a spider web to be placed in a sinus cavity after surgery that stays there for about a month and gets washed and dissolves away. But while it stays there, it slowly eludes topical steroid, so that instead of having a patient having to take oral steroids that go systemically, and instead of using sprays that may not get into the deepest crevices of the sinuses, this keeps sinus cavities open. So here's an example of a study done by the company who sells Propel, of Propel being placed in an open sinus space after surgery. And then in 30 days, the narrowing and polypoid changes that have recurred due to their allergies or chronic disease versus after the Propel where you have a wider opening. Really, the point of sinus surgery isn't necessarily to cure the disease forever. It is to help the sinuses function long-term better so that they can be washed and have steroid sprays to decrease allergies and other risk factors so they don't have problems. I love this slide. It's a great demonstration of the purpose of sinus surgery. So if we look on the right side, once again orienting you, this is the brain, these are the eyeballs, here's the teeth and mouth. This is the right nasal cavity, and this side has not had surgery. So you can see, to draw a line in the nose, in the middle meatus, under the middle turbinate, around the uncinate process and into the sinus, look how narrow this opening is. This is a 1 or 2 millimeter area to ventilate. In surgery, we cut the uncinate process, we cut this bone here, and we make an opening this big. So you can easily see the difference of how much congestion it would take to obstruct this sinus and get a sinusitis versus obstructing this sinus. Nevertheless, there are patients who have tight anatomy and still do not have a lot of chronic swelling or disease. And for years, we were stuck with a difficult challenge when a patient like this, who has no obvious sinus disease but has very tight anatomy, gets recurrent headaches every time she gets an allergy, or gets sinus infections that go away with just sprays, but this happens every single month. What do we do? And there were times when patients and I eventually made the choice to have sinus surgery, and they resolved miraculously, but they went through a hospitalization, general anesthesia, and recovery from surgery. Now there's a different way, and some of this technology has been taken from angioplasty and other disciplines of medicine. There's a better way that's better, simpler, safer, and easier, and that is using balloon technology. And with the balloon technology, you can go through an ostia, have a wire that passes into the sinus, and then place a balloon over the wire and stretch open the opening. This is not for everyone. This isn't going to help if you have polyps. It's not going to help if you have concretions or things that need to be removed from the sinuses. But if you have recurrent infections with minimal disease or mild chronic sinusitis, it's very helpful. So here's an example of how this occurs. In the sinus, this is the middle meatus I was showing you. A wire is passed. I'll show you in a moment how you confirm where you are. Then the balloon is dilated and removed, and the opening is enlarged, maybe 5 or 10 times. We can, this is done in the office under topical anesthesia. No pills, no injections, topical anesthesia. And you can confirm you're in the sinus because you have passed the wire into the cavity and you are lighting up the lateral maxillary sinus, which you couldn't get to in any other way, or you're lighting up the lateral superior frontal sinus. This is important because the ethmoid cavity is like a beehive with lots of pockets, and you could easily go into a pocket and say you're in a sinus, but without this confirmation, you would be incorrect. So I'm going to show you a little video of how this process works. A catheter is placed into the nose while the patient is awake and numbed, and then we're going to show you a little anatomy inside. The wire is passed up along the anatomy until we direct it through the ostium, and this is the ostium of the frontal sinus, into the frontal sinus, and you're confirming light up here on the forehead to know you're in the right place and you're not stuck in another cell. And then a balloon is passed over the wire, which I think they may have already shown, and water can also be flooded in the sinus to wash out thick mucus. And then the device is removed. The actual process itself maybe takes 15 minutes, but patients tend to be there for about an hour because I spend a lot of time numbing them and making sure they're comfortable and understand what they're going to experience. There are many benefits to balloon sinuplasty. As I said, topical anesthesia in the office, minimal pain. You're going right to the anatomical area of the natural ostia to improve ventilation. You're sparing healthy tissue. Nothing is being cut. Nothing is being removed. There's nothing to heal except that opening to heal at a wider space. It also preserves the option that if they still have problems or things progress over time in 10 years, they can have endoscopic sinus surgery. Probably the biggest thing is that they are not in the hospital for 2 hours, paying the cost of a hospitalization, general anesthesia, and having several weeks of recovery and restrictions because of the cut raw spaces in their sinuses. There have been many studies that have shown that balloon sinuplasty versus just more sprays and antibiotics, balloon sinuplasty has shown greater improvement in quality, and even balloon sinuplasty, where they didn't really inflate anything, has been shown against placebo. This is a patient that I did this procedure on years ago. So we want to talk to you about your balloon sinuplasty procedure.
Okay.
That was how many months ago?
7 months ago.
7 months ago. And the procedure itself was done in the office.
It was.
How did you feel with that procedure?
Oh, I felt comfortable. Everybody was very welcoming. Everybody was in the room with me. Yes, it was fine.
And do you remember the problems you had that caused us to do the procedure?
Oh, yes. I was miserable. I was having terrible headaches. I was irritable. I had a cough. I was getting frequent sinus infections. I just felt lousy, like didn't want to get out of bed.
And now, 7 months later, how do you feel?
Oh, 100% better. I'm up, I'm out and about. I joined a boot camp, so I'm out early in the morning exercising. I can sleep in on the weekends, which I couldn't do before because of the sinus pressure I had.
How is your stuffiness in your nose?
Gone.
How is your headaches?
Gone. I feel much better.
How is the constant cough?
Gone too.
And how is the fatigue that you had?
Oh, it's gone too. I'm up and out at 6 a.m. I'm out the door exercising.
Okay.
I feel much better. Thank you so much.
So in conclusion, sinusitis treatment has changed dramatically in the last 2 or 3 decades. The visualization with endoscopes has increased accuracy and safety. Balloon sinuplasty has given us another option to improve ventilation in a much less aggressive or invasive way. We use absorbable packing that allows us to cover the raw surfaces within a sinus cavity without having to rip anything out and cause bleeding and lengthen the time of healing. The tissue shavers have allowed us to remove polyps without removing normal mucosa. Sinus irrigators have given us a way to wash out thick concretions that are oftentimes difficult to get out in any other way. The drug-releasing dissolvable stents allow long-term topical steroid to prevent recurrence, scarring, and closure of the openings we're making. And another thing that I haven't mentioned yet is when people have these open spaces after surgery, if they do culture out difficult bugs to kill like Pseudomonas and MRSA, we use topical antibiotic irrigation now that is made in a compounding pharmacy. So they don't have to keep taking oral or even IV antibiotics that affect them systemically. And this works better than IV antibiotics, actually. And they can do this for 6 weeks, but it's only going to their sinuses and addressing the location where they have their bacterial infection. I thank you for your time.